doze off or something, just in case you remember this, you remembered a very important part of inflammatory bowel disease. This is biopsy-proven Crohn's disease involving the tongue. These are not aphthous ulcers or anything like that. This is Crohn's disease involving the tongue. And Crohn's disease can involve any part of the GI tract from the mouth to the anus, where ulcerative colitis primarily involves just the colon. So our objectives on the next slide will be to define IBD, review the manifestations, discuss various treatments, and then answer your questions. And we're going to have those questions at the end after all the talks. Next, please. What is inflammatory bowel disease? It is a group of diseases. The two most common are ulcerative colitis and Crohn's disease. Dan, if you could go back, thank you. And there's approximately 1.6 to 3.1 million Americans with this disease, and there's an increasing prevalence of this illness. Dan, some people cannot see the slides. Are you sharing your screen with everyone?
I believe so.
Okay. And the symptoms of the disease is different from person to person, which makes my job kind of difficult, as all of the other people, because every patient is very different. Next, please. If I knew what caused inflammatory bowel disease, I'd be some type of an important person, you know, many letters behind my name and stuff, but I'm just a regular gastroenterologist. We know that there's a genetic component. Something has to turn on the genes for it to work. You have to have the wrong immune system response. We know that the microbiota, or all the bugs that live in the gut, have to be involved. And then there's certain environmental exposures like smoking or quitting smoking can also turn on inflammatory bowel disease. Next. This slide, and it comes out about every 10 years or so, shows the incidence and prevalence of Crohn's disease. And the highest areas are those in red. And you can see the United States is mostly red. And over time, it's very interesting that the countries who are more US-like, more westernized, higher use of antibiotics, and more cleanly and more use of antibacterial products have a rising incidence and prevalence. So just keep that in mind when you are using all the antimicrobials that we have to use now to prevent COVID infections. But it's sometimes okay to get exposure to different pathogens along the way, especially when you're younger. Next, please. Crohn's disease, as I said on the first slide, can involve anything from the mouth to the anus, where ulcerative colitis on the right only involves the colon. Ulcerative colitis starts in the rectum, goes all the way up in a continuous and contiguous fashion until it's done. There are no skip lesions involved in ulcerative colitis, where Crohn's disease can involve the colon, can involve the small intestine, the stomach, the esophagus. There's usually more skip lesions. Now, patients don't always read all the books how they're supposed to act, and sometimes it's very difficult to tell who has Crohn's colitis and who has ulcerative colitis. Now, if there's small intestine involvement, you know it is most likely Crohn's disease. But if the colon is involved, sometimes it's very difficult to tell Crohn's disease from ulcerative colitis apart. Next, please. Most people with inflammatory bowel disease have had the illness for about 2 years before they're diagnosed. And This is not like the TV programs where everything is diagnosed within 30 to 60 minutes and everything's readily available. You don't have to get insurance approval for anything. And like I swear, those people don't have to take the colon preps either. So it's a process. And again, every patient doesn't present the same. You might need a physical exam, laboratory work, need some diagnostic tests, maybe some x-rays or MRIs or CT scans, colonoscopies, upper endoscopies, and other imaging tests. And then your provider will help determine whether you have more Crohn's-like disease or more ulcerative colitis-like disease. Next, please. Now, there are genes associated with inflammatory bowel disease, and right now there's 173 genes that we know are associated with IBD. But I rarely ordered these genes in my clinical practice because just because you have the gene doesn't mean you have inflammatory bowel disease. Something has to turn it on, so these are susceptibility genes. So it's not as easy as just getting a blood test in order to diagnose these diseases. Next. The incidence of inflammatory bowel disease is kind of bimodal, both in ulcerative colitis and Crohn's disease. So you can get the diseases at any ages. Very unusual under the age of 2 or over the age of 80, but it can happen. The most common age of diagnosis in each of the diseases is older children or young adults. So teenagers to early 20-year-old. But notice there's a second peak around the age of 50 to 60 where there's another peak incidence of diagnosis. Next, please. It's difficult to diagnose these diseases because every patient acts alike. Ulcerative colitis very commonly has diarrhea or bloody stools associated with it. But many of my Crohn's patients never have diarrhea. They might present more with abdominal pain and constipation. People might present with low-grade fever or just overwhelming fatigue. Sometimes their GI symptoms are fairly muted as well. So you have to have a high incidence of suspicion. When looking at the lab, it might give you some clues. For example, if the platelet count is elevated or the hemoglobin or the blood count is low, that might have you think about getting an endoscopy or a colonoscopy earlier on. But a wide variety of symptoms. So just because you don't have diarrhea doesn't mean you don't have inflammatory bowel disease, especially Crohn's disease. Next, please. There are complications to this disease, and we try to treat to prevent these complications. But especially Crohn's disease early on is a very inflammatory disease. And as the disease progresses, it turns into a more stenosing disease that can lead to obstructions. So it's better to treat early on when the disease is inflammatory rather than let it progress to obstructive disease with strictures. Fistulas are little burrowing tracts that burrow from one thing to something else. They're named from where they start to where they go. The picture on your bottom right shows an entero-entero fistula because it goes between bowel walls. That's a kind of a hallmark of Crohn's disease. Not everyone has it, but if you see fistulas, you should think of Crohn's disease as a diagnosis. Of course, everybody wants to prevent colon cancer, so the longer you have uncontrolled inflammation, the higher the risk of colon cancer. Next, please. Ulcerative colitis more frequently has anemia because most people with ulcerative colitis have bloody stools. The bowel wall becomes very thinned out, and so perforation or rupture of the bowel can be a severe complication of ulcerative colitis. And colon cancer is more prevalent in ulcerative colitis than in Crohn's disease. Toxic megacolon is a condition that we don't see nearly as often now as we did years ago because we have better therapy to treat ulcerative colitis. But it's when the bowel really becomes enlarged and looks like it's going to perforate. And so back in the day, that was treated with almost emergent colectomy or removal of the colon. Next, please. There's extraintestinal manifestations of the disease, and I'd like to move on to the next slide, Dan, please. This shows aphthous ulcerations, little sores on the tongue or on the buccal mucosa. It's very common. Not everyone with aphthous ulcers has inflammatory bowel disease. It's seen in both ulcerative colitis and Crohn's disease. And some patients will get these aphthous ulcers before they have a flare. As you get to know your disease, you might keep track of when you're getting oral aphthous ulcerations. Next, please. Another extraintestinal manifestation is iritis or uveitis or episcleritis. This usually involves a painful red eye with photophobia. This is not pink eye. And you can see that one of her pupils is much bigger than the other one. The eye that is all red has a very small pupil, and the other pupil is more normal in size. This is an ophthalmologic emergency. It needs to be seen by an ophthalmologist right away and treated. Next. These two pictures show erythema nodosum on the left, painful red bumps, most commonly on the lower extremities, seen more often in people with colonic disease and seen more often in women than in men. On the right, there's pyoderma gangrenosa, and this can be seen in either disease, a necrotic skin condition, again seen most commonly on the legs. Next, please. On the left is erythema nodosum that has ulcerated, and that is only seen in Crohn's disease. And on the right, another picture of pyoderma gangrenosum. And this picture I wanted to show you, it's a calf of a leg, so the backside of a leg, and pyoderma frequently has a purplish border around it. And if you biopsy this area, or if you hit the area or cause any skin disruption, you'll get another pyoderma right next to it. So often it's a diagnosis that you must make by looking at it. Now, to me, that's pretty evident that it's pyoderma, but how it starts, they look like little tiny purplish mosquito bites, more commonly on the lower extremities. Next, please. Arthritis is a very common extraintestinal manifestation of IBD. There's different types of arthritis, but most commonly it tends to involve one joint at a time. The larger joints are seen more commonly than the small joints. There's no synovial destruction. It's not like rheumatoid arthritis. You'll not get joint deformity. It is just very painful. Next, please. And here's Stacy, the same girl with that she had the uveitis, the eye problem. See, she's holding her little cloth there because she had it over her eyes because she has photophobia, or she doesn't like the light getting in her eyes. At the same time she had uveitis or eye problems, she also had a tender, swollen left knee. Next. So the comprehensive management of inflammatory bowel disease takes multiple people, and it takes a group of people to treat patients. So it's not just a single physician that can do this, but it's always our goal to keep patients in remission and maintain that remission. That's our most important goal as providers. Then, we might have to use the nutritionist to make sure you get adequate nutrition. We want to give you good therapy without causing much harm. So we want to minimize the treatment toxicity. Next, please. The treatment options, remember there's the prescription medications, there's over-the-counter agents, there's complementary and alternative therapies, and there's always surgery. Next, please. You really want medications that are inexpensive, they work quickly, and they work all the time. I wish there were those medicines because, as you all know, treatment for inflammatory bowel disease is very expensive and often involves multiple medications. Next, please. This is an older slide, but I think it really illustrates how we want to treat the disease early on. Because early on the left side of the graph, Crohn's disease in particular is an inflammatory condition. As time goes along, more strictures are formed, more fistulas or penetrations are formed. And all the medicines work better if you treat the inflammatory component of inflammatory bowel disease. Next, please. And as I stated earlier, there is a risk of ulcerative colitis. You see about the 10-year mark, the risk of colon cancer and ulcerative colitis goes up. And so that's why we start patients who have ulcerative colitis in a colon cancer screening program after 8 to 10 years. And I know every patient hates getting a colonoscopy because they hate the prep, but this is important, just like any colon cancer or other cancer screening mechanism. We do it because there's such a high risk of colon cancer. Now, you can decrease the risk of colon cancer by getting good control of your disease and taking your medications. Next, please. There's numerous medications, and if I went over each of these medications, we'd be here for a couple of hours. So just briefly, the aminosalicylates are really the baseline starting agent for ulcerative colitis. Then we move on to corticosteroids. They're great anti-inflammatory drugs, but they're really a short-term solution because they have long-term potentially lethal side effects. So a short-term solution, not a long-term solution. Antibiotics I use in my practice more often in Crohn's disease, especially in fistulizing Crohn's disease. Next, please. Then there's the immunomodulatory agents like the thiopurines, including 6-mercaptopurine and azathioprine, as well as methotrexate. Each of these drugs are used differently, or they might be used in combination with biologic therapies or the mesalamines as well also. Now, then we move to the newer therapies or the biologic therapies, and these have really revolutionized treatment of ulcerative colitis and Crohn's disease. There's different types, and you use different biologics depending on where the disease is and the activity of the disease. The newest kid on the block is the Janus kinase or JAK inhibitors, also called Xeljanz or tofacitinib, and its claim to fame is that it is an oral agent for ulcerative colitis. So it's a biologic agent that's taken as a pill. In adults anyway, this drug is currently restricted, so you really have to fail the other biologic agents before going to Xeljanz or tofacitinib because it does have the potential to cause blood clots. Next, please. And then the over-the-counter agents are also important. It's really important to discuss with your provider before taking over-the-counter agents. Anti-diarrheal agents can often help the person who has lots of diarrhea, but if you're having an acute flare and you have ulcerative colitis, you might not want to use that agent because it can stimulate toxic megacolon. Laxatives can be used for the constipated patient, and pain relievers are also sometimes used, especially for those patients with Crohn's disease. Next, please. And then what we try to do is prevent operations in Crohn's and ulcerative colitis, but that's not always possible. I use colorectal surgeons in my practice because they're a little more, have more expertise than the general surgeons, but sometimes depending on where you're living, you might use a general surgeon as well. Next, please. Then complementary and alternative medications. I am not the authority on this, but what my patients ask me about is marijuana. First, it is illegal in the state of Nebraska. I will say that. And there is no good controlled studies that show that marijuana or marijuana products do anything to control the inflammation of either ulcerative colitis or Crohn's disease, but they might help in pain management. As many of these complementary and alternative medications can help along with your other prescribed medications. Again, always telling your provider what you're actually taking, what you're putting into your body as well. And then next slide. Quick moment on pregnant women. You can get pregnant and have healthy children even if you have ulcerative colitis or Crohn's disease. The most important consideration is you should have good control of your disease before getting pregnant. Many of the medications can be continued in pregnancy, but not all of them. Next, please. So the best advice I can give to you is keep your follow-up appointments, become compliant with taking your medications, or tell your provider why you can't take the medications. Understand your disease and the possible complications, so be a partner with your physician or provider in establishing a good care for your disease. Maintain a well-balanced diet. Establish a support system, for example, the Crohn's and Colitis Foundation, and empower yourself with new information. And Dan, I think I'm on time, so we're on to the next speaker.
Thank you, Dr. Young. And I want to just give a brief thank you to a few of our sponsors. Altus Infusions, we treat each patient like family. Takeda, Better Health, Brighter Future, and AbbVie and Prometheus Labs. Thank you so much for your support for this event. I also want to thank our volunteers, including our speakers tonight, and our support group facilitators, our Take Steps team captains, our board members. It really is amazing to work for this foundation and see the passionate volunteers that we have that support us. Next, I'd like to introduce Dr. Helen Fasanya. Helen, are you off mute?
I'm here.
Okay, great.
Okay.
I think your slides are queued up.
All right. Hi, everyone. Thank you for joining us, and thank you to the Crohn's and Colitis Foundation for putting on this patient education meeting. So I will be speaking to you about the effect or the relation of COVID-19 to your inflammatory bowel disease, and what you as a patient should know and what your caregivers should know as well. Next slide. So we have heard the terms coronavirus, COVID-19, SARS-CoV-2. They have almost become household terms, at least since sometime in the beginning of March, but even maybe longer for some people. We know by now that there are many human coronaviruses. They have been around for many years. Some may cause mild respiratory illnesses, and some may cause severe respiratory illnesses. I just noticed my slides are not showing up great here, but the CDC definition for COVID-19 is that it's a new disease caused by a novel or a new coronavirus that hadn't been previously seen in humans. And that coronavirus is SARS-CoV-2, and that's the coronavirus or COVID-19. I'm sorry, I'm going to go into there. So COVID-19 stands for Coronavirus Disease 2019. And the reason that we have 2019 there is that it was first reported in December of 2019. And it is caused by the severe acute respiratory syndrome virus, coronavirus 2, which is the novel virus that hadn't been previously seen in humans. Next slide.
Sorry, Helen, there seems to be some lag going on here. It's not letting me advance the slides.
Let me go off of my.
There we go.
Okay, so it's important to know the impact of coronavirus. This is a scary time and it has been impactful. We've been hearing about it. Not a day goes by without us hearing about the new cases. So to date, there have been over 6 million cases diagnosed in the United States alone. And this virus has been responsible for a little bit under 200,000 deaths in the US. Next slide, please. In Nebraska, as of yesterday, when I uploaded this, there were 38,335 positive cases with SARS-CoV-2 in Nebraska. And in Iowa, there were just a little less than twice that number at 75,277. So this is an impactful infection and disease in this part of the world, in the United States in particular, and it is important to know about it. Next slide. What are the symptoms of COVID-19? So the most common symptoms are viral symptoms: fever, shortness of breath, cough. Some patients will present with headache, myalgias or body aches, fatigue. And then more recently, we've heard more patients present with gastrointestinal symptoms. We've also seen more studies showing that perhaps more patients than what we thought before do come in with one or more gastrointestinal symptoms. And these include diarrhea, nausea, vomiting, abdominal discomfort. We've heard more and more about a decreased sense of smell and taste and decreased appetite. This can be very confusing for patients with inflammatory bowel disease whose main symptoms are gastrointestinal distress. So it's hard to know if the diarrhea is a flare of your symptoms or if it's actual COVID-19. And then to complicate matters even further, any infectious process can cause a flare of your underlying inflammatory bowel disease. So bottom line here is pay close attention to your body and your symptoms. Are your GI distress symptoms accompanied by a fever or progression of other symptoms like shortness of breath, headache? We know that majority of patients who present with GI distress won't just present with GI symptoms. They also typically have accompanying symptoms of fever, shortness of breath, cough. The bottom line, again, is discuss with your primary, with your doctor, with your gastroenterologist, with your GI health care team, with your primary care doctor as well. Ask for advice or schedule a virtual visit. Next slide, please. So this is a scary time. Obviously, we're all worried. Should we be going outside? Should we be going back to work? Should our kids be going back to school? Should we be wearing masks? In general, there shouldn't be any argument about these preventative measures. These are general precautions that have been shown to reduce the spread of coronavirus, reduce the spread of SARS-CoV-2, COVID-19, and prevent you from contracting the disease. In general, we touch, breathe, and inhale these viral particles, so it makes sense that washing your hands frequently and efficiently, so at least 20 seconds at a time, and then using hand sanitizer with at least 60% alcohol if soap and water are not available to you. That's a very standard measure that has been proven to decrease the spread of infection. Staying home if you can. Telecommuting, that's not a luxury for everyone, but it is possible for some. Staying home, particularly if you're sick, and then asking your healthcare team, your gastroenterologist or your primary care doctor for an appeal letter if you're concerned about your work environment or school or what have you. And if you have to go outside, then wearing a mask if possible, keeping that 6 feet social distance in. And then keeping your commonly used surfaces, the touch surfaces, clean with alcohol, with bleach. And the safe products can be found on the foundation's webpage. If you have a cough or a sneeze, make sure you cover your cough or sneeze when you do that. Throw away any tissues that are used right away, and avoid touching your face, your eyes, your mouth if you haven't washed your hands yet. Next slide. So the main question that majority of you have is, does the diagnosis of inflammatory bowel disease, does your inflammatory bowel disease increase your risk of COVID-19 or the risk of a bad outcome should you contract COVID-19? So we do have a great registry called the Secure IBD Registry, which is an international registry that was set up earlier this year with the start of the pandemic, and it was set up to help define the impact of COVID-19 on inflammatory bowel disease. And healthcare providers have been reporting their patients with inflammatory bowel disease and COVID-19 to this registry anonymously. So this is a de-identified registry, but this registry has helped us understand the impact of COVID-19 on IBD. And what we've learned from it so far is that there seems to be no increased risk of contracting the SARS-CoV-2 virus with inflammatory bowel disease. So there isn't any inherent risk of increased risk just because you have Crohn's disease or ulcerative colitis. And we also haven't seen worsened outcomes with COVID-19 and inflammatory bowel disease patients. One thing that is important to remember is that in a patient with inflammatory bowel disease, the immune system is actually overactive as opposed to underactive, and the diagnosis of inflammatory bowel disease doesn't make one inherently immunosuppressed. The opposite is actually true because the immune system is overactive, and so we use medications to bring that immune response down or to modify that immune response. So therefore, patients with Crohn's and ulcerative colitis are not inherently immunocompromised. However, some of the medications that we use to modify that immune response can immunosuppress you. Next slide. So this essentially says the same thing that I just mentioned. Although the medications that we use suppress the immune system or modify the immune response, what we have seen from the Secure IBD Registry is that these medications, although they do increase the risk of other viral and bacterial infections, have actually not increased the risk of SARS-CoV-2 or COVID-19 disease. Next slide. Dr. Young went over the medications that we typically use for inflammatory bowel disease, so I won't belabor the point. The bottom line in this slide is that the main overlying recommendation from our expert consensus from the experts, as well as all of your physicians or majority of your physicians, is that you should continue taking your medications as prescribed. Do not stop your medications. The majority of your medications are safe to take, and in fact, it's safer to stay on your medications because having an inflamed bowel can make it easier for the virus to come in and to cause an inflammatory response and disease, so to speak. So these medications may actually have some protective effect, and the overlying recommendation is that you stay on your medications. You don't delay your infusions. You don't delay your taking your medications. The one caveat to this would be the steroids, and I will talk about that in just a short while. Next slide, please. So again, stay on your medications, do not delay therapy. If you are concerned that you have had an exposure to someone with COVID-19, or you have symptoms that are concerning for COVID-19, please contact your healthcare team, because this is a topic that is a little too complex to make recommendations or guidelines for every specific issue. So in various cases, your primary care or your gastroenterologist or your healthcare team may decide to hold your particular medication for a period anywhere from 10 to 14 days, depending on your specific situation. So if you have been exposed to someone with SARS-CoV-2, we know that if you are going to go on to develop COVID-19, you most likely will develop those symptoms within a period of 14 days. In fact, most patients will develop those symptoms within 5 days, but 14 days is a safe enough marker to say that if you haven't developed symptoms at that point, you likely will not develop symptoms and you're safe to continue with your medications. But if there is a true exposure, or there are certain symptoms that are concerning for COVID-19, in the right scenario, we may want to hold your particular infusion to allow your body to respond to the virus, respond to the infection, and to get rid of the infection on its own. So contact your healthcare team, your gastroenterologist, if you're concerned about this. Next slide, please. A note about steroids. Again, steroids are not maintenance medications, and they're never meant for long-term use. There are some patients who are steroid dependent, and that means they are unable to get off of steroids, and we realize that there are cases like that. So every case is individual, and one should work with their doctor in every specific case. But we do know that based on research from previous SARS epidemics, steroids like prednisone can make patients worse. And in general, if you're on steroids, you should be working with your doctor to taper the dose down to a level where your GI symptoms are controlled, to minimize complications, because there are several complications, not the least of which is an increased risk of COVID-19 and worsened outcomes with it. However, having said that, we don't want you to stop your steroids suddenly. So someone who has been on steroids long term and stops their steroids all of a sudden can have even worsened outcomes, including hospitalization, the need for intensive care unit, and even death. So these medications are very strong. They need to be tapered off slowly with the guidance of your doctor. So if you are on these medications, make sure you talk to your doctor about the importance of them and how you can go down to a dose that is less, a dose that puts you at less risk overall. Next slide, please. In children, I'm sure Dr. Kunnath will touch on this, but looking at data from China so far, as well as the secure IBD registry data, most cases in children have been mild or asymptomatic. We know that children can be asymptomatic carriers of the virus. And overall, there's limited data on effects of COVID-19 on children with IBD. What we know from the secure IBD registry is that so far in children under the age of 19, we've had 192 cases reported to date. And in that particular category, there have been no deaths. There was one patient who required intensive care unit stay and ventilator, but overall, very good outcomes in children. So again, the recommendations for children are the same. Stay on your medications, follow precautions and healthy practices. And for children who are on nutritional support, continue that nutritional support, because that can be important in maintaining intestinal health, which again can decrease your risk of infection overall. Next slide, please. If you are on medications that require an infusion, I know there's been a lot of concern about going into infusion centers. Experts have determined that infusion center infusions are overall safe as long as they have certain protocols for specific for COVID-19. So the considerations that are important to think about for your infusion center is, do they have a screening protocol for symptoms of COVID-19? And is there adequate social distancing or spacing that's 6 feet apart at least? And are they restricting visitors? Are they utilizing masks for both patients as well as the healthcare team? If you are one of the patients who's receiving home infusions, talk to your doctor to ensure that that is a safe option for you. In general, it's thought that infusion centers are safer than home infusion, so I wouldn't recommend one to switch from an infusion center to a home infusion setting. However, we do know that in some patients, home infusions are necessary for one reason or another. So this is something to discuss with your doctor if this is a safe option for you. Something that is really important is, if you have certain symptoms that are concerning for COVID-19, contact your infusion center, your care manager, your healthcare team, your doctor before you go into the infusion center, especially if you have a fever that's greater than 100.4 degrees Fahrenheit, or if you've had a new cough or a new shortness of breath in the last 2 weeks, because again, these could be symptoms of COVID-19, or if you had a known exposure to someone with COVID-19, because you may be placing someone else at risk, and you may also not need that particular infusion at that particular time, because your team may decide that holding it for a period of a few days or up to 2 weeks may be the best option for you. So contact your care team before you go in if you have any of those concerning symptoms. Next slide, please. So this is a really stressful time, and emotional and mental health is important now more than ever. It's important to realize the impact of all of the news and the stress in this. As a patient with inflammatory bowel disease, you're living with stress every day, and this has to be an even more stressful time. So take time for yourself. Spend some time where you've turned off the media and you're not getting overloaded with information about COVID-19 and additional stress. Develop a plan, for patients who are staying home, who are telecommuting, who have a different schedule. Develop a plan for your day so that you're more productive during the day, and you set some time for yourself for mental health. You're eating healthy meals, or you at least have some time to prepare those healthy meals. Go out for a walk, but follow social distancing. Wear a mask if you are going to be coming in contact with other people. And then make sure you have the supplies that you need so that can decrease your level of stress. A quarantine may not happen again, but in the event that it does, I think just having those supplies puts your mind at ease, just knowing that you will be prepared. Make sure you have your medications, a good supply of medications available to you. That takes one stress factor away. And find some coping mechanisms that work for you. Yoga, meditation, all of these things, adequate sleep, getting fresh air, all of those are important now, particularly more than ever. there are support groups. The foundation has support groups, and you can find those on the website. It's sometimes important to connect with other people who are dealing with what you're dealing with, just to hear how other people are managing or just commiserating with someone else. Next slide, please. With children who have inflammatory bowel disease, as a caregiver or as a patient with inflammatory bowel disease who has children, it's important to talk to your child, because they are watching, they are listening, and they are aware. And some of that misunderstanding or lack of proper understanding could increase their stress level. So it's important to not forget them and to explain to them as much as you can in simple terms, obviously not scaring them, but comforting them in that you have control of the situation, and sort of being supportive to them, answering their questions, and then reminding them of those preventative measures, the hand washing, being a role model for them. Let them see how you try to prevent the spread of this disease, and then also let them see how you cope with this through yoga, meditation, and all of that can be done as a family. Art projects and forms of exercise could all be helpful for your child, but also overall as a family to do to decrease stress. Next slide.
Sorry, Dr.
That's
Fasanya.
okay.
It's got a mind of its own.
If you're an essential worker, essential care worker, you may have some questions, you may have some added stress, you may be concerned about your likelihood of exposure to the virus. What's your risk in terms of the medications that you might be on, and how can you limit your exposure? I encourage you to talk to your doctor about any concerns that you may have. And if you are for some reason very concerned about your assignment. For instance, I've had patients who are nurses who have been assigned to the COVID-19 floors, or other, you don't have to be a nurse to be an essential worker. Talk to your care team, because they would be happy to write you an appeal letter, particularly if this raises your stress level. If you are able to wear a mask, an N95 mask, make sure that you are practicing those personal protective measures as well. Having said all of that, I just want to reiterate that having Crohn's disease and ulcerative colitis does not increase your risk above the risk of that of the general population. So we know that even in patients with inflammatory bowel disease, the increased risk of COVID-19 really comes from having another comorbid illness, and that includes heart disease, underlying lung disease, which includes smoking as well. Unfortunately, obesity and being overweight, underlying, I already talked about lung disease, diabetes also increases that risk. But Crohn's and ulcerative colitis by themselves do not increase your risk of SARS-CoV-2 or COVID-19. And also, just as we talked about, your medications do not increase your risk of worsened outcomes or contracting this virus. And we know this to be true for the anti-TNFs. We also know this to be true for the other biologics or biosimilars. We know this to be true for the aminosalicylates and the thiopurines, as well as the new kid on the block, the JAK2 or JAK inhibitors. Prednisone, like we talked about, does increase your risk, and so you should be practicing extra careful measures if you are on prednisone, and if you have been deemed to be the prednisone has been deemed necessary for you. But if that's not the case, then talk to your doctor about tapering off of prednisone to reduce your risk. Next slide, please. So again, research is underway. We're continuing to learn more about the impact of COVID-19 as it pertains to inflammatory bowel disease. We talked about the Secure IBD Registry, which is a de-identified registry of international extent, and it's completed by healthcare professionals. And there are multiple groups that are working towards getting more data as it pertains to inflammatory bowel disease and COVID-19. You can find additional information on these websites as well as from the foundation. Next slide, please. This is just a snapshot of what the Secure IBD Registry looks like as of September 8th. I had mentioned that there were 192, a little bit more, kids who were diagnosed with COVID-19 who also have inflammatory bowel disease. And so this comes from this particular registry. There doesn't seem to be a big difference between men and women as it pertains to inflammatory bowel disease, but you can see that the risk of poor outcomes, and what I mean by that is the risk of the need for intensive care unit, ventilator, or the risk of death, does not seem to be any different than what it is in the general population. And I'm not sure if you can see this on your screen, but yes, I think you can. Again, those who are at most risk are those over the age of 60, and in particularly those over the age of 80. I think that's perhaps the conclusion of my slides. Yes. You can learn more about inflammatory bowel disease and COVID-19 by visiting the Foundation's website. There's constant re-updating of information and links to additional sites with more updated information.
Thank you, Dr. Fasanya Uptagraft. She is with Midwest Gastrointestinal Associates in Omaha, Nebraska. We really appreciate you presenting tonight. Next, I'd like to introduce Dr. Sharad Kunnath with Boys Town National Research Hospital, also in Omaha, Nebraska. Dr. Kunnath?
Thank you, Dan. Thank you, Dr. Fasanya, Dr. Young. You guys have done a wonderful talk. And I think you've covered quite a few of my slides. And since I had quite a few that were assigned, I think I'm going to skip through some of them just for the sake of time today. But I have been assigned to talk about the pediatric aspect of IBD and the subtle nuances that relate to pediatric manifestation here. So IBD in children shares a lot of things that are common with adult counterparts, but there are a few aspects of it that tend to be a little different, and it's good to know that. So children presenting with IBD at diagnosis tend to typically have a little bit more severe presentation. We think that almost 20% of them have signs of abscesses or narrowing of their gut or fistulas, which sometimes requires us to get our surgical colleagues on board. When it comes to things like ulcerative colitis, most pediatric IBD patients present with what we call pancolitis, which is the complete colon being inflamed. And so that's a little different from the adults, I believe. And because of this, children also end up with a lot of growth delays. There's delay in many other aspects of their life because, as you know, young adulthood, teen years is a period of maturation, physiologically, puberty, sexually, bone health, so many aspects of it, and those all get affected by that. This certainly has a lot of impact on children emotionally, psychologically. They're not often adept to handle that. And medications can also are a little bit more harder to give them because their bodies haven't matured as much on that. Next slide, please. So as Dr. Young already elucidated, IBD is pretty complex. We don't know exactly what causes it, but we do think it's an interplay, like she mentioned, with genetics and environmental factors. We do think that earlier the incidence of IBD, the more often it's the genetics that's taking a part in it. And in fact, in most of our children who get diagnosed under the age of 5, which we call very early onset IBD, They often require a significant genetic workup with our genetic physicians to look at mutations, and that can sometimes help us know whether there are other underlying entities going on too. Next slide, please. So about a quarter of patients who are diagnosed with IBD are pediatric, and I think we saw the slide before with Dr. Young, and the peak that we see in pediatrics is typically around that 14 to 16 year mark. But we do see them as young as infants and of course older teenagers too. Next slide, please. So IBD in pediatric patients shares many things that's common with adults. The disease is essentially the same physiologically, pathologically, at a molecular basis, it's the same. Things that you would need to rule out to diagnose IBD pretty much is the same too for the most part. What makes it a little trickier is the fact that we don't have specific pediatric data. That goes in the entire world of medicine. Most studies in terms of medications are done on almost always on adults. As pediatric physicians, we have to extrapolate that data from adults and use that in children, tailor that to them. So that can be a little tricky. And of course, kids present with a lot of growth and developmental issues that make it sometimes a little bit more challenging. Next slide. So the treatment of pediatric IBD, the goals remain the same as it would be for all patients with IBD. It's of course getting the disease into remission, treating the patient, minimizing toxicity from medications, but also that's a little bit more specific here is really improving their growth and nutrition. Most patients with IBD in pediatric clinics are presenting with at least some evidence of growth failure, some evidence of malnutrition, and that certainly has to be addressed while we're treating the condition too. Next slide. So health maintenance, we're all very well versed with well child visits for our children, taking them to the pediatrician. Children need to be screened more often for many other conditions and to just be sure that they're growing healthy. So in IBD too, that is an important aspect. Next slide. So we really need to, as caregivers, as gastroenterologists, pediatricians, really be kind of have kind of a low threshold to screen our children for underlying conditions that can affect their IBD and overall outcomes. Next. Dr. Fasanya has already addressed a lot of the COVID-19 concerns. As she mentioned, patients with IBD are not particularly immunosuppressed, but they certainly are a little bit more prone to certain infections, and we just have to have a little bit more higher alert for that. Vaccinations across the board are always encouraged. There's always concerns that parents bring whether the vaccination was the cause for IBD or whether it will worsen it, and we always have to encourage them and say that no, this is what is really important to prevent other conditions that could make their IBD worse and overall impact their health. Next slide. So when it comes to vaccinations, we follow the American Academy of Pediatric schedules for vaccinations across the board. The only caveat there is that we don't recommend live virus vaccines for most of our patients with IBD because those have the potential to replicate and cause the similar disease in those patients. Next slide. Dr. Young and Fasanya have discussed some of the medications. As you can see, most of these medicines, whether it's prednisone, immunomodulators such as azathioprine, biological therapy, all of these medications are ones on which we would recommend patients not receive the live vaccines. Next slide. The good news is most live vaccines are in pediatrics are usually offered early in life before most of them have developed IBD. For example, the rotavirus, the MMR, the chickenpox vaccine, all of these are usually given in early childhood. And so most patients, pediatric patients who are presenting with IBD have already received those live virus vaccines and are up to date on that. So that's a good thing about that. But these are the live vaccines that we would avoid in any patient with IBD typically. Next slide. Almost 90% of the vaccines that are administered in pediatrics are actually inactivated or killed killed versions of the vaccine, and hence are safe and are recommended across the board. Next. So in terms of health maintenance, there are a few things I want to touch upon. Strong bones, cancer prevention, I think Dr. Young has already talked about, medication monitoring and psychological support. Next slide. So bone health, so period of adolescence, teen years, period of extreme growth is a time where most of the bones are getting mineralized a lot. So this is the time where you really expect the bones to get really strong, to get thicker, and to get really healthy. So during this time when kids are being diagnosed with IBD, it can be because of the lack of nutrition, the fact that the intestines are not absorbing the nutrients as well, or they've been on medications such as steroids, which can cause sometimes bone thinning. These are the times when the bone gets affected. Next, please. So the modality that we typically use as pediatric gastroenterologists, at least at diagnosis, we always get a study called a DEXA scan or a bone density scan. We typically do one again every few years during the period of growth. And if there's evidence of thinning of bones on these studies, then we usually really optimize the nutrition, get them to be on calcium, vitamin D supplementation. Really getting the disease under control is also an important aspect of getting the bones to get healthy. Very rarely do they have to refer them to physicians who may have to put them on special medications for that. Next, please. I'm not going to elaborate on this. Dr. Young talked a little bit about it, but it's just importance of screening. Next slide. The most important aspect of this really is, and I'm just going to belabor the point here, is to preventing colon cancer, reducing the risk of it really is dependent on controlling the disease and keeping it in remission. That's what really helps it a lot. And of course, a good healthy diet. Next slide, please. Skin cancer risk also there, and tanning is a very frequently used thing nowadays among our teenagers, young adults, and something to be discouraged. And of course, if there are any lesions, then we often will refer them to our dermatologist friends. Next slide. Tobacco use, particularly is more harmful for a patient with Crohn's disease. It's a good thing to remember that even secondhand smoke, that means parents or caregivers smoking, can also have a similar effect on children. And we also have been seeing a lot of young teenagers and young adults who have been vaping, e-cigarettes, coming in with lung injury when they've been on some of these biological therapies. So I think there's a lot of evidence that it can be harmful in many ways for them. Next slide. So medication specific testing. So these are kind of routine testing that we do on our pediatric patients to screen for any abnormalities that may be coming up because of certain medications that they're on. If we're starting patients on biological therapy, we will always screen them for tuberculosis, for certain other fungal infections. This may be periodically done every few years too. If they're on aminosalicylates for ulcerative colitis, then we may also check their urine every year. We'll always look at their white blood cell count, the liver enzymes, kidney functions. If they're on biological medications, checking their levels to be sure that that's therapeutic and that they're not creating any antibodies to that. Next slide. I think Dr. Fasanya talked a little bit about mental health, but it's important to recognize that children are not small adults, and the diagnosis and the burden of IBD is certainly a hard one for adults, and it's even more harder for our pediatric patients. They're really not meant to carry that, and they need all the support that they need from their caregivers, parents, physicians, and other people in their lives. Our data suggests that almost 15% of patients with IBD in the pediatric world probably have anxiety and depression. And screening them for some of these things, keeping a low threshold to look for some signs that may suggest that, and involving caregivers and helping that is a good thing. Next slide. In our practice, we have psychologists who specialize with treating patients with anxiety and depression in IBD, and I think that's a good resource to always have. The good news is I think most of them do recover and respond to a lot of behavioral therapy, but I think CCFA also has a lot of forums and support systems in place, and those are things that we can always reach out to also. Next slide, please. These again, some of the websites that are there and available on the CCFA website. It talks about Just Like Me, IBD, Campus Connection for kids and teenagers in high school or transitioning to college. Good resources that can help them through this process. Next slide, please. I'm not going to talk about this. Dr. Fasanya has already talked about it. I would only say that I can skip to the next one too. It's good to be aware that children often will internalize and have to be prodded a little bit to talk about their stress and anxiety. And social media, you know, our children nowadays are almost stuck to their phones more than adults. And I think this is a good time for them to realize that this is can sometimes be counterproductive, and finding human relationships, human bonds in family, friends is a good way to get rid of a lot of the stress that they may be feeling with all this COVID and IBD issues. We'll step to IBD and nutrition in the pediatric world. Next slide. So growth issues tend to be, as I mentioned, very common in pediatric IBD. Tends to be a little bit more common in Crohn's disease than in ulcerative colitis. The real reason being that in pediatric IBD, the small intestine tends to get very often involved and affected. And the small intestine is where a lot of our food digestion and absorption takes place. And because that gets affected, children present with growth failure, they fall off the growth chart, there's a lot of weight loss and signs of malnutrition. And knowing the growth window is a period of extreme growth during those years, and that differs depending on the sex. Females tend to have an earlier growth window, males tend to have a later growth window. But knowing that growth window is crucial for patients if they're being diagnosed before that, to be able to get them to a place where they're healthy before they hit the growth window. And for those who are being diagnosed in the growth window, to really be aggressive about getting their disease under control and getting optimal nutrition so that they can at least recover some of their growth potential. Next slide. So principles of good nutrition. Good nutrition is really important, really to help heal the gut. The gut is extremely inflamed. And while we need all these medicines, without proper nutrition, the gut really cannot heal up. So that's an important aspect of nutrition. And of course, it improves the energy level, and as we talked about, helps with growth overall. Next slide. So people with IBD, particularly children, we always say avoid restricting any major food groups, avoid going on tangential diets, try to incorporate a wide variety of food items, whole foods, limited processed food is good. I always tell my patients, it's good to have cheat days where you can eat all the junk you want, but 90% of the time at least aim to eat healthy, because we are what we eat eventually, especially in the IBD world. When you're flaring, you may have symptoms because you eat certain food items. In the world of Google nowadays, everybody can Google and find out what are the triggers, but it's important to recognize that what may be my trigger may not be somebody else's trigger. And so it's good to keep a food journal and to know what are the things that bother you when you're going through a flare. Next slide, please. So these are some of the common trigger factors. Food items, high fiber can be bothersome for some people, lactose, gassy vegetables, spicy food items, etc. Next slide. And recognizing these are the triggers and avoiding them in your diet when you're going through a flare is probably a wise thing. Next slide. Just want to touch on a few aspects of nutrition here. Protein needs, especially for young adults, teenagers, young children, protein needs are higher because of growth. It's also important to recognize that the inflamed gut is leaking out protein during this time, something called protein losing enteropathy that happens especially in patients with Crohn's disease. And so it's important to be cognizant of that and be sure that they're getting good sources of protein in their diet, healthy sources of protein, and utilizing dietitians or reaching out to physicians for more advice on that is also a good thing. Next slide. Fats are not bad. We say actually healthy fats are really good component of the child's diet. Adding healthy fish such as salmon, tuna, olive oil, coconut oil, all these kind of healthy fats is a good thing to help with some of the inflammation that they're experiencing in their gut.
Go away from home.
Next slide. Calcium again from bone health aspect.
Well, I just wanted to invite you then. The Thanksgiving is at my house.
Everybody, please put yourself on mute.
Calcium is important for patients just for the bone mineralization aspect of it. Most patients with IBD can handle, in the pediatric world, can handle dairy products because they really haven't had what we call adult onset lactose intolerance as yet. For the few who can't even handle that, low lactose dairies there, such as hard cheese, thick yogurt, and other non-dairy forms of calcium too. We also recommend calcium supplementation, particularly if we see some form of thinning on the DEXA scan. Next slide. Next slide.
Sorry, Dr. Kunnath, it seems to be stuck again. I apologize for that. Give it one moment. It seems to just take a little while. Here we go.
So key points when it comes to diet. Parents will often ask me, is there something that we ate that caused it? Or is there something that we can take out of his diet that will prevent it? And that's a good question, but the answer is no. There's no one food item that caused it. There's no one food item that can prevent it. There's no one particular diet that can manage your IBD, but variations in the diet can certainly help with improving their overall growth, getting them to a healthier state. And it may need to be individualized based on what kind of a disease they have, what part of their gut is inflamed, and what kind of catch-up they need to do for their growth needs. Next slide. These are again some of the resources that are there on the CCFA website. Next slide, please. The goals of pediatric IBD patient management are similar to that of adults. A few key factors, just to reiterate, are always assessing our patients for growth failure, growth delay, nutritional malnutrition, signs of malnutrition, and doing early intervention to improve that. Addressing some of the psychosocial issues that children can certainly suffer more from because it's a greater disease burden on them. And finally, working and getting our pediatric patients to a place where they can understand the disease, can take some steps in learning how to manage their medications or even their clinic appointments, preparing them just as in every other aspect of life, preparing our kids to a place where we think that they can become successful adults. That's an important part of the whole process here. Next slide. And so So that's the slide. It starts with a place where they need a lot of support from family, and there's a period of growth, psychosocial development. They get trained and educated in the condition, and finally they're able to reach a place where they can take full control of their condition, and are probably at that point ready to be transitioned to adult care. Next slide. So I just want to end with this Camp Oasis slide. Missouri and Minnesota have these camps every summer. All the IBD patients, pediatric patients who've gone there have always loved it. It's a great place for them to meet with fellow friends and people who share the same disease, and to learn and to feel more at home about it, and to recognize that they're not the exception, and the people are doing well with this condition. So I would encourage parents who have children with IBD to really consider sending their children there. It's a great resource, and I thank CCFA for that. That's it.
Thank you, Dr. Kunnath. I would like to introduce Aaron Castens. He's the executive director of our Nebraska-Iowa chapter, and he hosts events like our Take Steps Walk in Iowa and Nebraska, and our gala, and he'd just like to come on and say a few words to the group.
Yeah, thanks, Dan. Hi, everybody. Like Dan said, I'm Aaron Castens. I'm the executive director for the Nebraska-Iowa chapter for the foundation. Just want to thank Dr. Kunnath, Dr. Fasanya, and Dr. Young for your time tonight. Appreciate your expertise. I'll share a couple different things. I am happy to speak with any of you. A lot of you know me. I see some familiar faces and names as well. But for those of you that aren't familiar with the chapter, we have a great community of support. So if you're interested in connecting with other people that are impacted by these diseases, certainly check out our Facebook page or our chapter website, or reach out to us as staff or some of our volunteers, excuse me, and we'll be happy to connect you with others. It's just really important for us to be raising awareness for these diseases, and obviously raising critical funds for research and all of our patient support programs like Camp Oasis. So if you want to connect with other people or get involved in the community, certainly reach out. We're here as a resource to help you navigate your journey with IBD, and hopefully eventually end these diseases. So thank you guys for tuning in this evening. And again, thank you to the doctors for their fantastic presentations.
Great. And now we'll move into the question and answer portion of this evening. And the first question I have, I'm going to direct to Dr. Fasanya Uptagraft. What about Entocort? Is it the same as prednisone as far as increasing risk, assuming they mean risk for COVID-19?
So we don't have data specific to Entocort, but what I can say is that Entocort, although is a steroid, it is in the class of steroids that are very poorly systemically absorbed, so have very limited systemic absorption, meaning that they don't have the immunosuppression that prednisone has. And so the treatment that comes from budesonide or Entocort is very localized to the area where the drug is released, which is in the intestine. Very little of it gets systemically absorbed, and over time that could potentially cause some immunosuppression. But overall, the way that we use budesonide for a short period of time, budesonide should not have the same concern that prednisone does.
Thank you. The next question we will direct to Dr. Kunnath. Did the gene tests help to predict whether or not a child of a person with Crohn's will have IBD?
No, it will not. I think Dr. Young had also talked about it. We don't do gene testing on kids because those who are not affected, because just having those genes doesn't mean that they will develop it. There's a lot of interplay with factors in the environment or other factors that need to trigger that off before IBD can develop. So it's not beneficial to do that. Besides, I don't think most insurance companies will cover that either.
Okay, and this one we'll send to Dr. Young. Can you be on medications like mesalamine and Lialda long-term? I didn't quite catch what she said about that.
Drugs like mesalamine would be considered safe in long term. Of course, you should continue to see your physician. I monitor for renal function, like Dr. Kunnath said, that at least once a year, monitoring for renal function. Every medication has potential side effects, even the ones you get over the counter. So, but in general, mesalamine is considered safe for long-term use.
I think this one we can send to Dr. Kunnath as well. Assuming routine childhood vaccinations have already been given, what vaccinations are commonly recommended for Crohn's patients when diagnosed at age 20?
At age 20, I think that may be better answered by my
Okay.
adult friends.
Dr. Young, you're on mute.
Yeah, sorry. So if I had a 20-year-old that was going to go on, for example, biologic medications, I would vaccinate them early for pneumonia and make sure that they have antibodies to hepatitis B, and if not, revaccinate for hepatitis B.
Okay, and the next one we'll direct at Dr. Fasanya Uptagraft. If a portion of the small bowel has been removed, 45 centimeters, along with strictureplasties, is it recommended to follow up with physical therapy who specializes in pelvic floor strengthening?
Could you repeat the question?
Yes, if a portion of the small bowel has been removed, 45 centimeters, along with strictureplasties, is it recommended to follow up with the physical therapy who specializes in pelvic floor strengthening?
So I usually refer patients to physical therapy, pelvic floor strengthening, or pelvic floor physical therapists when they have issues with the pelvic floor. And in inflammatory bowel disease, pelvic floor issues could arise in patients who have had some sort of surgery in that region, and that could be an ileorectal anastomosis, for instance, in patients with Crohn's disease who have had their entire colon and rectum taken out, and then the ileum connected to a small remaining part of the rectum. Or a patient with previous ulcerative colitis who has now had a colectomy with J-pouch creation. Any type of surgery in that region can cause some pelvic floor dysfunction, weakening. But even patients who just have had long-standing inflammatory bowel disease can have scar tissue formation and poor function of that pelvic floor region. And so they may benefit from pelvic floor physical therapy. So the key symptoms for that referral would be fecal incontinence. And sometimes we, not only fecal incontinence, but patients who are struggling with sort of functional bowel symptoms, diarrhea alternating with constipation, may benefit from some biofeedback, which the pelvic floor physical therapists do. I can't think of anything in particular that would make me refer to pelvic floor physical therapy because of a small bowel resection or a strictureplasty, but I guess I don't know the specifics of this particular patient. They may have some connection to the rectum. So this is something that your doctor could, and even your care manager or the nurse practitioner taking care of this could maybe further advise on. Dr. Young, I don't know, you might have something more to add.
I would agree with what you've said, but I would agree just if they've had a small bowel resection and strictureplasty, I wouldn't automatically refer them to physical therapy unless they had documented pelvic floor dysfunction.
I will send this one to Dr. Young. A patient, Crohn's patient, also deals with periodontal disease, arthritis, and has had breast cancer. And she's looking for a food or natural therapy to help with inflammation in the body.
Well, I think we'd all like that. I can't give you a specific diet that would necessarily cure all of those medical problems. As the speakers have previously talked about, just a good nutritional diet with all food groups, non-fatty meals. Try to get in as much fresh fruits and vegetables as you can. Many patients with Crohn's and colitis are limited though because of their disease with what they're able to eat. But applesauce is not bad if you can eat apples, things like that. So I don't have a specific diet other than a healthy diet that I would recommend.
Okay, and this one I will direct to Dr. Fasanya. Uptagraft. Is it safe to go in for procedures right now, or should these be delayed?
So now that some of the restrictions are being lifted, I think it's safe now more so than it had been before. But even in the past, majority of your centers had specific processes in place that were very COVID-centric, whether it was testing for COVID-19 prior to the procedure or practicing extra measures to decrease the spread, that it has been safe for quite some time. And so in the event that your physician decides that a procedure is necessary at this point, I would not delay, but this is also something to discuss with your care team, your physician, and ask this question, particularly if you are concerned or if you are in that category of increased risk, so over the age of 60, or you have another comorbidity, including heart disease, lung disease, you're a smoker, which you hopefully aren't, you're overweight, or you have diabetes. I mean, those would be very valid concerns. Could we postpone this very routine colonoscopy for a few months? And in the event of routine procedures, that could certainly be done. However, at this point, that would not be necessary, as I believe that it is safe currently.
This one is also COVID-19 related. There have been some reports that some IBD drugs could have a protective effect in COVID-19. Is that true?
So this is a complex question, but I think it's a good one. Certainly, there's been no studies that have shown that any of our IBD drugs are suitable to treat COVID-19. But perhaps to alleviate some fears in some people, if I haven't already, yes, these drugs could potentially have a protective effect. And that's not just by decreasing inflammation and improving the quality of the bowel mucosa and preventing viral entry, but also by reducing that cytokine storm that we've heard about, that inflammatory response in COVID-19, in that phase where patients can go really south or get better. There has been some thought that the medications that we use to modify the immune response in inflammatory bowel disease do the same in COVID-19 and modify that immune response, thereby reducing it. So this is not a ploy this is a medication for COVID-19, but it's more so to perhaps alleviate some of those fears.
We will take one more question, and this one will go to Dr. Young. What do you recommend for nausea that doesn't respond to medications, including Zofran, Phenergan, Marinol, and Scopolamine?
Maybe a reevaluation as to whether you have a strictured or narrowed area in the bowel. Maybe repeat upper and lower end endoscopy to see if there's untreated inflammation. You know, there's other causes of nausea too, and this gets into more general medicine, but maybe imaging of the head, including the brain, just to look for other etiologies of nausea that someone could have, especially when they're not responding to good anti-nausea medications.
I had one more just come in, and I think this is an important one. Would you recommend giving vaccinations, including flu vaccine, during an infusion? I'll take anyone's answer.
I'll let Dr. Young take it.
20 years ago, I didn't let anybody get a vaccination with the infusion, but I've changed significantly based on studies that have been published in the past. And if the only time you're going to be there for a vaccination, it's better to vaccinate even though you're getting an infusion.
That's is going to conclude our presentation tonight, and I'd like to thank everybody for joining us, and I'd especially like to thank our presenters. They're really what has made this event possible. Thank you so much, everybody, and have a good night.
Thank you.
Thank you.
Thank you.
Thank you.